So, welcome back, everybody, to the podcast. It's really great that you can join us. My name is Dr. James Waldron. I am a GP in Nottingham and a GPnotebook educator and podcaster. This is part of our series about hepatology and hepatitis, and I'm really glad to be able to welcome you to our special guest for today, Dr. Rik Fijten. Welcome, Rik.
Thanks, James. Thanks for having me today.
Brilliant. Tell us a bit more about yourself.
So I'm a GP partner in South East London, and I also have two other roles that have a hepatology or gastroenterology focus. So one of which is my Hepatitis C GP Champion role for Bexley, and I also work as a GP clinical fellow in the local gastroenterology department at one of our local hospitals in South East London. So yeah, very pleased to be here today.
And we're really grateful to have you. Certainly, GP with extended roles really important for us to get our teeth into some of these really interesting topics. And I suppose a less common extended role, but a very important one, as we are soon to hear. So, we are talking today about hepatitis C. Why is this such an important topic, Rik?
So I think it's a really, really important topic, and one which I think as GPs and healthcare professionals, we don't get much teaching on at university or in our careers. So it's a condition which we've seen huge advances in the treatment of over the last 5 to 10 years. And it's a condition that is now curable with really, really effective treatment that patients can access. So historically, the treatments had varied success rates associated with quite significant side effects, but now that's all changed. And actually, what we want to do as Hepatitis C GP champions is increase awareness about the condition and make GPs and other healthcare professionals aware of how we can diagnose this in practice, but also how we can get patients into the services that they need to get into to access this treatment.
I mean, that's wonderful. And I just think it's worth pausing there for a second, because in medical school, which for me was not so long ago, but I mean, further when, I thought this wasn't a thing that we could treat. This wasn't a thing that was curable, or at least not to my mind. But we've got a situation now where we can potentially cure a disease that was a limiting and a very concerning condition for many. So I think that's just amazing. I just want to highlight that to our listeners.
Yeah, so it's a real success story, I would say.
And I guess that this puts it on one of the top of the things that we want to do. And it's also kind of links into the general NHS priorities at the moment.
Yeah, absolutely. I think we'll speak about it in a bit more depth shortly, but I think the the Hepatitis C Elimination program has really is an example of how we can move sort of care from hospitals to the community, from sickness to prevention, and also from analog to digital. And I think we're definitely doing that with the Elimination program, and we've seen real successes in terms of prevalence of hepatitis C, access to treatment in communities who often find it difficult to engage with treatment, and you know the mortality rates associated with hepatitis C are at an all-time low. So it's really good to see.
And that's great to hear. And I think that primary care has got a unique and important role. Well, in fact, in all healthcare, but certainly in this aspect, because a lot of patients are going to be asymptomatic, as far as I'm aware. I think that a lot of the time people don't know they've got it until it's either very late on. So it's about surveillance and about being curious as to when we might be looking for it.
Absolutely. And it might be helpful just to go over just the basics of hepatitis C for the listeners.
Absolutely. It's a thing that I probably looked at a long time ago, but
Yeah.
yes, catch us up.
So hepatitis C is an RNA virus, and it's an oncogenic virus. So if left untreated, it will lead to fibrosis, cirrhosis, and then in some patients, in a percentage of patients, HCC, hepatocellular carcinoma, which has very poor prognosis. Um, hepatitis C is predominantly spread through intravenous drug use. It can also be spread through sexual contact, and there are multiple risk factors which I think we all need to be aware of, which as you've mentioned, the point about being curious are crucial in understanding, so that when we are seeing patients in practice or looking at results, we have that curious hat on and we're looking at their risk factors. So, for example, the main risk factors that we would be thinking about is, anyone who's got a history of intravenous drug use, or any recreational drug use, men who have sex with men, sex workers, and then thinking about patients who are from countries where the prevalence of this disease is much higher than it is in the UK. So Africa, Central and South America, parts of Eastern Europe. So I think that's really, really key. There are other risk factors, including homelessness, people who have been in prison in the past, and of course those who have received a blood transfusion before 1996. Those are key.
So I think that sounds important, and just to kind of, we have such a diverse society in the UK, which is wonderful. But again, our suspicion needs to be aligned to our patient populations, and asking people about things. But of course, it's can be quite a difficult conversation to have. Are there any tips and tricks you might give us to start this conversation with people, or any pitfalls we might encounter?
Yeah, it's a really good question. I think as we've seen with the successes with HIV testing, and trying to reduce some of the stigma associated with um, HIV, is I think about normalizing the conversation. So when you are speaking to someone about, and most commonly it will be, maybe an abnormal blood test, specifically the liver function test, is normalizing the fact that as part of your investigations, you would include a test for hepatitis C. Hepatitis B is also very important, and we are going to do another podcast on that, and HIV as well. So I think normalizing that conversation, or that point, will allow patients to understand. And I think sharing some of the information, which hopefully we can share in the show notes with you, that you can use that to support that conversation with your patients. Your question about pitfalls, I would say that it's about explaining to the patient, or avoiding scaring the patient. Hepatitis C, as we've said, is curable. And actually, the most important thing is doing the test. And if we do identify it, that's a success, because once they're established on treatment, they will be cured.
Yeah, and I think that it's worth mentioning here, as we did a number of times throughout our HIV series of last year. Worth checking that out for those of you listening at home if you haven't. Avoiding stigmatizing language and making sure that it is inclusive, and understanding that this is a difficult conversation for people. And as we were talking about this before, I think one of the things that came up was that sometimes people that have had a history of intravenous drug use aren't so forthcoming with that information.
Absolutely. And I think this is a really important point to just touch on and think about, a case that I've discussed at previous podcasts, but it was a lady who was 65. She came in to see her GP for some routine blood tests, and was found to have a mild transaminitis on her blood tests. The clinician went through all sort of risk factors, and discussed the blood tests. She denied any alcohol excess. She'd had a hepatitis B immunization schedule. She was slightly overweight, so the feeling was this was metabolic dysfunction associated steatotic liver disease.
Yeah, muzzled.
Yeah, exactly. But on further questioning, she did mention that in her youth, she used intravenous drugs. As a result, a hepatitis C test was done, and it came back positive. She was plugged into treatment, and the outcome was positive. but it just shows it's very easy to not ask about that, um, because patients won't often volunteer that information. So just being curious.
Yeah, I mean, we can imagine can be challenging conversations in a lot of respects. I think the way I've been trying to approach this as part of my sort of journey through understanding more about HIV and hepatitis is just to normalize the conversation. And I tend to get in a situation where it's like, well, we're going to check for this. These things are treatable. If it's positive, we'll deal with it. And if it's negative, great, we know. And I think that I suppose not exceptionalizing that conversation, but of course keeping it I suppose clinically relevant is still really important, isn't it?
Yeah, absolutely. And I think most patients really value that, and often the response is very positive.
Brilliant. Well, I mean, we're talking about Hep C now, and we've talked about the amazing factor that we can cure it now. Why is it the sudden chat about hepatitis C? Why is it so much in our mind and in the public eye?
So I think it really stems from the hepatitis C elimination program, which was built on the World Health Organization's desire to eliminate hepatitis C as a public health threat. And this came in 2015. And on the back of that, in 2019, the hepatitis C elimination program was born, and it was really built on collaboration between the different healthcare sectors, but also the pharmaceutical industry, to improve access to treatment, uh, to also increase awareness of the condition, and improve referral pathways at a primary and secondary care level. Um, and that's the work that I've been doing alongside my local operational delivery network. And it's been a real success. So I think that's one of the big factors. Yeah, it's fantastic. And one of the other factors must be, which we should touch on, which is very important, was the infected blood inquiry, which was published in May 2024. Um, and it was, for those listeners who, I'm sure everyone has heard of this, uh, but it was felt that about 30,000 people had been infected with bloodborne viruses through receiving contaminated blood products between 1970 and 1998. And of course, hepatitis C is one of those. So, really, really important, really topical. Um,
Yeah, and I guess that's definitely worth bearing in mind, that this is something that's been in the public eye, and there'll be plenty of people that will received blood transfusions quite a long time ago, and just to consider that that's potentially a reason why one might get checked, and. You mentioned 30,000 people have thought to be infected. I guess that there may well still be people out there that haven't been tested and investigated.
Yeah, absolutely. I think it's estimated that we have roughly 50,000 people living with hepatitis C who have yet to be diagnosed. So there are definitely those patients out there. And I think, as you've mentioned, in primary care, we're in a really strong position to make a positive difference to those patients.
Mm, brilliant. Okay, well, I mean that is so important, and it's really good that it's come to the public's attention. But we've got something we can do so effectively about it. When should we be thinking about testing? I mean, is it just after exposure? What sort of things might prompt us to start thinking down this line?
Really good question. Um, I think there are a number of scenarios where we would think about testing. So one, someone might present acutely. Um, you know, they have a history of intravenous drug use, and actually they're trying to, um, engage with um, investigation and treatment. And of course, in that scenario, you would be doing the test, but be mindful that if you are doing an antibody test soon after potential exposure, this might come back falsely reassuring. So think about retesting these patients at 3 to 6 months to ensure that you have an accurate result. Um, Other scenarios would be patients presenting with very non-specific symptoms. So on the whole, patients will not have any symptoms. However, we see a lot of patients have mild, sort of non-specific abdominal pain, nausea, um, fever, not as common in hepatitis C. However, think about it and think about those risk factors that we've discussed and think about offering the test. The other scenario would be, as we know, we are looking through lots of results day to day, and when you're seeing an abnormal liver test, this is an opportunity again to think about hepatitis C and think about adding on hepatitis C antibody test to your set of blood tests. In practice, you might not do it for everyone, and I think we have to be realistic. If you have a diagnosis and they have no risk factors, you might not do it. But I think what I'm trying to, hopefully the conversation is achieving, is improving or increasing, sorry, awareness amongst the listenership. So those would be, I think, the main scenarios where I would be thinking about it. And of course, risk factors are key.
Yeah, absolutely, and that is nice and clear for when we should be thinking about it. You mentioned the looking for the Hep C virus antibody. Again, I think for those of us that remember the days of medical school, being presented with antibody and core antigen and similar, how do we interpret those?
Really good question. Much easier than hepatitis B serology. One thing to say is that about 20% of patients who are infected with hepatitis C will clear the virus spontaneously without treatment. Okay, so when you're doing your test, and this will vary depending on the area that you work in, but often the laboratory will run a hepatitis C antibody test. If that comes back positive, it suggests that someone at some point in their life has been exposed to the virus. And again, this will vary, but in our local area, they will reflex the test and give you an RNA level. If that RNA level comes back positive, that is active hepatitis C and needs treatment and referral. If the RNA comes back negative, then the result, the antibody positive results suggest past exposure, which has been cleared.
Brilliant. Oh, that's great to hear. And I seem to remember learning during medical school as well that if you are infected with hepatitis C, that doesn't necessarily become chronic. Is that right?
Yeah, so it very much depends on again, as I mentioned, if you cleared it yourself, if you've got an RNA positive result and a positive antibody test, that would be active chronic hepatitis C, depending on when you're exposed, and would need treatment to ensure that resolves.
Yeah. Okay, so we've been talking and we've heard a lot about this miraculous new treatment and amazing things that we can do with it. So the scenario being that a patient's come in, we've identified that they've got hepatitis C, the RNA positive. What next?
Really good question, and one that hopefully I can reassure your listeners that should be relatively straightforward to manage. So I think important points would be reviewing the patient clinically. Okay, making sure that they're not systemically unwell with any, they're not jaundiced, they don't have any right upper quadrant pain. Of course, if they were to have those, then I would be referring them same day into an acute hospital for review. If they are well, which often patients are, and asymptomatic, then the next step would be follow your local path, your referral pathway, and again that will differ between areas, but essentially you are referring to your local hepatology service. If you're unsure, then I think we now have access to advice and guidance. We have in some areas Consultant Connect, or you could speak to your local gastroenterology registrar for advice, and that would be those would be the important steps. I would also say that it's important to think about who's at home with this patient, any potential exposure there, and thinking about offering a hepatitis C test to anyone that might have been exposed.
Brilliant. Oh, that's great. I think looking at the patient holistically and in the whole context is so important and a real step that we can make in general practice. What does the treatment actually look like? What are they likely to receive in the clinic?
So yeah, this is where there's been real advances. So we now have direct acting antiviral medicines, which are oral medicines, once daily regime for 12 weeks, which have about a 98 to 99% success rate.
Wow, gosh, that's high.
Yeah, it's fantastic. So to put it in context, now in our local liver centre, patients are receiving hepatitis C positive organs, organ transplant, and they are then being started immediately post-operatively on hepatitis C treatment because it's that effective.
Wow, that's amazing. And side effects to expect?
Minimal, very minimal. And again, it's in terms of thinking about access, and often patients who are affected by hepatitis C, um, may be suffering from homelessness. They might be sex workers. They may have recently been in prison, and they often have very difficult lives. And actually, this medicine can be administered in the community through the right services. It's an oral medicine, so again, improving engagement with treatment and compliance is something that this treatment has definitely been successful in doing.
And that's amazing. And as far as I'm aware, it is in such contrast to the medications that were available before, which of course a lot of us in healthcare and a lot of patients will be pretty terrified of. And so I think, yeah, I think it's really important we get that message across, isn't it?
Yeah, absolutely, and I'm sure that over the coming years, with hopefully the shift to from hospital to community, we'll see that there are more services prescribing these medicines for those that need it.
Absolutely wonderful. So they've had the treatment. We've hopefully got this 98% cure rate. Now what? Do we need to monitor them? They need scanning? Do they need retesting? Where are we at in primary care?
A really good question. I think once you've referred into hepatology, they will do the rest. And I think as GPs, we don't have to really worry from that point on. Some will need ongoing surveillance in hepatology depending on other risk factors. Um, but I would say the main probably learning point, and one that I would like to convey, is most patients will be successfully treated. This doesn't mean they can't be reinfected. Yeah, so if we are seeing them again down the line and you know, they've been discharged from hepatology, these patients are still at risk of hepatitis C. So always think about retesting because they have risk factors.
I guess if the risk factors continue.
Yeah,
Yeah.
exactly. Yeah, so that would be probably my main learning point, not to sort of disregard their risk if they've already had that treatment. Still think about offering a new test if the situation were to arise.
Well, that's amazing. I think we've been through such a journey on this, like just finding out that there is an effective, low side effect, single course treatment for what was just even a few years ago, and essentially an incurable, life limiting condition for a lot of people. I think it's amazing.
Yeah, it's fantastic, and um, the work that primary care have done with colleagues in secondary care and in the community has been absolutely instrumental in achieving that. So it's great.
And true collaboration is
Yeah,
just amazing when it happens, isn't it? Well, that was a really wonderful walk through hepatitis C, and thank you so much, Rik, for joining us. I think hopefully we can get people interested in hepatology and bloodborne viruses, and just what we can do now, because this is a new day, and it's wonderful the advance we've made.
absolutely. Really enjoyed today, and hopefully the information that we've shared will allow GPs and other professionals to feel more confident having those conversations and offering tests to patients who might be at risk.
Wonderful. And I'm glad to say this is not the end of our series on hepatology and hepatitis. We're going to be talking Hep B next time.
Yeah, absolutely. So another really interesting topic, and again, one that's probably poorly understood by most. So yeah, I would really looking forward to that.
Brilliant. And also just hepatology in general. I mean, because the biggest aspect here is that we start to talk about metabolic medicine and the whole patient. So we're going to be exploring that as well.
Absolutely. So yeah, really, really looking forward to it.
Well, thank you everybody at home for listening today. I hope you've enjoyed it. I hope you've learned something. Please spread the word about the amazing work that is going on in the world of hepatology and bloodborne viruses. I hope you've enjoyed it. Please join us next time and tune in for our next GP Notebook podcast, and hope you have a wonderful day. Thank you.